So good evening. Thank you for coming. Smaller crowd tonight, but as I say, more intimate setting, and hopefully ask questions as we pursue. This is the 7th summer of this Healthy Living Lecture Series. It's brought to you by UAF Summer Session, Lifelong Learning, and significant support from Fairbanks Health Partners, owner and operator of Fairbanks Memorial, Tanana Valley Clinic, and Denali Long-Term Care Center. I'm Mike Powers. I'll be introducing tonight's speakers. I want to point out other upcoming UAF summer lectures. Author's Corner on Monday nights, and next Monday will be poet Linda Schandelmeyer with her collection of poems Coming Out of Nowhere. Healthy Living, of course, is on Tuesday. Discover Alaska, which are wonderful presentations on often overlooked local organizations, events, personalities. That wrapped up this week. And then on Thursday is Music in the Garden, and it'll feature the E.T. Barnett String Band with UAF Chancellor Dan White on the banjo. These summer lectures and performances are the result of Michelle's vision and hard work building on UAF's historic outreach to the community. I just want to mention the effort that Michelle has taken over the years in demonstrating the value that the university adds to the community's quality of life with the depth and breadth of lectures, courses, international programs, school programs offered through her department, Summer Sessions, Lifelong Learning. Important reminder, university policy now requires wearing a face mask for those indoors on campus, regardless of vaccination status. And for those live streaming tonight's discussion, please note the link at the bottom of your screen, which will allow you to submit questions. With that, let me introduce tonight's speaker, Dr. Erick Martell, originally scheduled to be on site for this lecture, but is wrapping up some commitments in Virginia at the moment and will be joining us via Zoom technology, which means it is 11 p.m. Eastern time, his time. Many thanks for his willingness to flex his schedule at significant inconvenience, I'd suggest, to present tonight's topic. Dr. Martell is a graduate of the George Washington University School of Medicine, Washington, D.C., served at general surgery at Tripler Army Medical Center, fellowship in plastics in reconstructive surgery at the University of Miami Jackson Health System, board certified by the American Board of Surgery, the American Board of Plastic Surgery, and is a fellow of the American College of Surgeons. Dr. Martell has extensive military healthcare experience, including Chief of Plastic and Reconstructive Surgery at Fort Belvoir, Virginia, formerly Chief of Surgery at Tripler Army Medical Center, including Chief of Surgical Subspecialty Plastics, Vascular, Cardiothoracic, Neurosurgery, Wound Care. Among many service awards, he's received the Meritorious Service Award, the Army Achievement Award, the NATO Medal, Army Achievement Award, and the Humanitarian Service Award. Academic presentations include, among others, treatment of early stage breast cancer in the elderly. He's authored an academic chapter of a book related to aesthetic surgery on the face, and he has performed humanitarian services in Haiti, Indonesia, Cambodia, related to cleft lip and palate repairs. Joining Dr. Martell via this Zoom connection in person, just to help with any local logistic questions, are to my right, Susan Bass, FHP, Director of Plastic and Reconstructive Surgery, Veronica Pera, First Assist in the OR, Plastic and Reconstructive Surgery, and Amy Sharp, Plastic and Surgery Practice Manager. Please join me in welcoming Dr. Erick Martell via the Zoom technology to present this evening's Healthy Living Lecture. Thank you. Dr. Martell?
Yeah, thank you. Thank you for allowing me to give this presentation. This is a Zoom presentation, as you've noted. I'm still in Virginia, and if there's any technical difficulties, just please stop me, just let me know. I want to give a sort of introductory talk about plastic and reconstructive surgery in Fairbanks particularly, and all it has to offer and what it encompasses. This is a very broad talk, and it's very difficult to give such a wide breadth of a discussion and in an hour format. However, what I want to do is be able to give a taste of what plastic surgery is and what we'd be able to do and offer the community in Fairbanks. So the scope of plastic surgery is rather broad. It's really different than what people may see on television or have a concept in American culture. It is often said that plastic surgery, we operate on the skin and its contents. And what that really means is we operate all over the body, from the top of the head down to the toe in different areas. And we'll work with a lot of different services. For instance, in trauma, majority will be facial extremity trauma. There'll be burn and frostbite injuries as well, which will be in our purview. Cancer reconstruction, breast cancer, facial skin cancer reconstruction is a very large part of plastic surgery's skill set. Congenital defects, whether it's hand congenital defects, spinal bifida congenital defects, or cleft lip and palate or VPI surgery, is also something that's in the purview of plastic surgery. Also, medically indicated procedures such as a breast reduction or a paniculectomy or scar revisions and things like that. Those are all in the purview also of plastic surgery that people may not be aware of. The more common things that people think of in plastic surgery would be elective cosmetic surgery, both invasive and non-invasive. What I mean by invasive is sort of anything that would involve someone going to the operating room and then getting an incision and altering the body through a traditional surgical methods. Non-invasive surgery has sort of increased over the past 10 to 15 years, but the technology really has exponentially grown over the past several years. And that is basically forms of either skin peels, lasers, intense pulse light therapies, radiofrequency ablation, things like that, which, and all these things I'll discuss and give examples of so that you can sort of be familiar with that. And traditionally, plastic surgery is chronic wounds. We deal with chronic wounds. And that really is, and I'll talk about this a little bit later, is plastic surgery kind of grew from a subset of specialties on dealing with chronic wounds. And from there, we developed a certain set of surgical principles, and the specialty has grown from there. So we're actually a very young specialty, only within the past 100 years as an organized specialty, but we've been practicing, or people have been practicing plastic surgery for thousands of years before it was traditionally known as plastic surgery. Chronic wounds will be traditionally on patients of the trunk and lower extremity, whether they're sacral wounds, whether they're trochanteric wounds, ischial wounds, or lower extremity wounds from either diabetes or trauma and things like that. So the history of plastic surgery, there's actually no plastic involved in plastic surgery. Even though silicone implants or saline implants involve a silicone elastomer, there's no plastic polymer that's used as traditionally thought of as in plastic surgery in American culture. The term plastic comes from a Greek terminology, is to form or to give mold or to reshape into form. And that is where it comes from. And plastic surgery is actually documented to be actually performed in 800 BC in India by Sushruta. And he had a compendium of treating different type of nasal defects, because unfortunately during that time, a form of punishment was amputation of the nose. So therefore, there was a lot of experience, a lot of sort of trauma where they had to try to reconstruct the nose. And that is actually the first documented plastic surgery procedure at 800 BC. From there, the Italians were deeply involved in the formation of plastic surgery. And this sort of schematic on the right is just a representation of the same procedure, reconstructing the nose. However, it's from the tissue of the arm. And if you look at the sort of the drawing, the arm is attached to the head, and there's a piece of tissue that actually is coming from the arm over to the nose in order to reconstruct the nose. And this was documented and sort of popularized by Gaspare Tagliacozzi, who is also known as the father of modern surgery, where it started to become documented and it started to travel throughout Europe and into other parts of the world. However, the term plastic surgery wasn't really sort of named or sort of was even an issue until 1818 by a German doctor by the name of Karl Ferdinand von Griffe, who described the process of molding the body. And that is traditionally where the name plastic surgery has come from. Now I'm going to delve into some sort of examples of what we're talking about when we're dealing with that. So we're going to zoom up to 2020 and 2019. As we know, COVID hit the world pandemic over the past year and a half. So all surgical procedures really took a very hard hit. But if you look at the column to the right, there are 15.6 million cosmetic procedures done in 2020. And this is in light of a COVID pandemic. And if you look at the bottom left, 6.8 million reconstructive procedures were also performed. So even though we had a global pandemic where almost every specialty was affected negatively in terms of what we can do because of the efforts and so forth was towards COVID, it only went down about 14 to 16%. So that just shows you the demand of cosmetic surgery, even during a time of a pandemic. If you look at the second column, the top 5 procedures of cosmetic surgical procedures, as you can see, nose reshaping, also known as rhinoplasty, eyelid surgery known as blepharoplasty, facelift, liposuction, breast augmentation. If you look at these numbers, there are over 1 million of these 5 particular procedures that were done in 2020. And if you can see the negative sort of downfall of the numbers from 3% down to a negative 33%, again, due to the COVID pandemic. With that being said, cosmetic surgery, sort of minimally invasive procedures were also very common. If you look at Botox injections are 4.4 million procedures, filler injections are 3.4 million procedures, and laser resurfacing is almost 1 million procedures in of itself. The only sort of plastic surgery procedures that kind of stayed the same or increased were tumor removal at 5.2 million, maxillofacial surgery, usually a result of trauma, hand surgery. All of these procedures went up even in spite of a COVID pandemic. When you look at the demographics, people typically will think of a plastic surgery procedure to be done by the younger population. If you see the teenage years from 13 to 19 years old, most of the procedures are minimally invasive procedures, things like chemical peels, fillers, Botox, PDO threads, which we'll talk about a little bit later. But the mainstay of the demographic population is between 40 and 54 years old. 6.1 million cosmetic procedures are being done. 700,000 of them being surgical and 4 million of them being minimally invasive. Even in our patients who are 70 and above, there's still a great demand of 250,000 cosmetic procedures in this age population. So plastic surgery encompasses all sort of age groups, all ethnicities, and both sexes that people will desire cosmetic surgery. And this is sort of the scope and the depth of breadth of where plastic surgery reaches. So trends in plastic surgery. Plastic surgery has been changing like most other fields. However, I feel that we've had most of the change because there's been new innovation. In other subspecialties, they've made a lot of strides over the years, and their sort of inroads were made over time. However, due to technology, fat grafting, molecular science, and things like that, plastic surgery has come into the forefront of doing things. So in terms of cosmetic surgery procedures, everyone knows of a mommy makeover. Well, now males are actually getting more procedures and called a daddy do-over. And these will typically sort of come in the form of high definition abdominal liposculpting, also known as abdominal etching. They'll also do this in combination with magnetic muscle stimulation treatments. And of course, gynecomastia, which is male breast tissue reduction, is also a very common procedure. In terms of non-invasive technological advances, there has been a wide variety of expanding non-invasive treatments and techniques. There has been things such as PDO threads, and these are polydioxane threads that were actually inserted through the superficial portion of the skin to give a lift to maybe the cheekbone or the jawline or the neckline or even the nose. And these are sort of minimally invasive, sort of short-term, back to work easy, low risk procedures that are actually cheaper than an invasive procedure, less recovery, less commitment, that people are actually flocking to at this particular point in time as well. Radiofrequency dermal rejuvenation is another thing. Sort of the traditional liposuction treatment where everyone thinks of put a probe within the skin and removing some of the fat. Well, radiofrequency ablation actually heats the outer tissue and the inner tissue to specific temperature goals, to therefore they're remodeling and shrinking the subfascial system and actually tightening the system. This is something that was not available not more than 3 to 4 years ago. So technology has really impacted plastic surgery in terms of the new sort of treatments that are coming out. Also, laser skin treatments in terms of actual laser therapy or intense pulse light therapy. Those are also very, very popular. And buccal fat reduction, sort of permanent cheek etching, is also very popular. All of these treatments here have low downtime, back to work, back to your lifestyle much quicker, least invasive, and less risks, and sort of more benefits, and actually a less cost to the patients as well. In terms of Botox has been one of the things other than medical marijuana that has found an application for almost every aspect of medicine. And cosmetic, it started out with cosmetic surgery as a non-invasive procedure. However, then it expanded into migraine therapy. Now it's expanded into weight loss therapy, hyperhidrosis, a lot of different other areas. Well, now we have something called baby Botox, which is microinjections of Botox for a more subtle look. In terms of the 80s and 90s, it was much more common to have a drastic sort of look where people can actually spot out a difference in terms of you having surgery. Now they want subtle differences. And one of those things is sort of a lip flip. You can actually do microinjections of Botox to semi-paralyze certain muscles and actually give more volume to certain areas of the face. And that's actually much more common to getting full facial Botox, where it's a little bit more obvious and people are looking towards a more subtle and more natural look. The microinjections of Botox also has been used just skin rejuvenation, of actually injecting very micro aliquots of Botox injections into the subdermal area and actually stimulating more glandular growth and more of the adnexal structures so that you can get more of a healthy skin and sheen look to it. Also, which is very interesting, is the Generation Z entering the aesthetic market. These are the very young individuals who were born in between the late 90s and early 2000s, who are online natives. And what they do is they will go to the online social media as their source of information and actually source of what is common and what is trending. And I have to admit, I even go to social media at times to go see what is trending and what people are looking for, because these things will change on a constant basis. They will change from region to region, different age groups, and some procedures may be dropped and other things are trending very, very short period of time without particular rhyme or reason. However, this is where the global market is going in terms of marketing to patients, because the Generation Z is also a large population, but they're actually more committed into doing procedures that are more preventative in nature and less surgical. So that is a very an area where plastic surgery is trending. I like to go into the crux of plastic surgery, though. We talked about the cosmetic portion of it, but really what we did was we formed because of trauma. And this is an individual with a gunshot wound to the face. As you can see, extensive massive injury through the commissure of the mouth and the teeth to the parotid gland. So what we're able to do is reconstruct this actually within the emergency room at that particular location. And the picture to the right is sort of the resultant defect, the tissue that you cannot get back that has to heal by secondary attention. However, with adequate monitoring, close follow-up, we're able to get the individual to a little bit better healing process on the terms on the left. And then the patient actually has some scarring, but much, much less than when he started with the gunshot wound to the face. And this is really the crux of plastic surgery. In terms of the injury, plastic surgery depends on principles. We stick to the principles of surgery in terms of healthy tissue, replacing like tissues with similar tissues to itself, making sure we have adequate blood supply, making sure there's no infection, and making sure we have a tension-free closure. We can actually do anything to the body. And as long as we adhere to those principles, we can apply the same principles to the face, to the arm, to the toe, to the back, to the stomach, to the scalp. It really doesn't matter. That's what's intriguing. And to me, quite fun with plastic surgery is that we're able to look at something and plan it and actually come up with a coherent thought process and try to tackle that problem. Here's an individual who had a very full thickness scalp defect. In terms of, if you really look closely, the outer table of the cranium is actually denuded and it doesn't have any blood supply there. So what we did was we burred down the outer table of that cranium and skin grafted this temporarily, and then expanded her scalp over a several month period of time and able to close the full defect itself. So this is pretty remarkable sort of a reconstruction that you don't really have a playbook for. You can't plan for something like this. But again, if you have your principles of plastic surgery in terms of, like I said before, clean, healthy wound edges, making sure there's no infection, tension-free closure, and adequate blood supply, we can apply those same principles to any injury of the body. And this particular patient went about maybe 7 to 8 months of surgical procedures in and out of the operating room, but we're able to close her scalp and protect her cranium, because if this wound had broken down, and that bone had denuded, her brain would be exposed, and obviously that's not compatible with life. So even plastic surgery will affect people's lives greatly. Here's a patient with cancer of the face, and this is a Mohs reconstruction procedure. In this procedure, the patient had underwent Mohs excision where the skin was removed, part of the cartilage was removed, and actually part of the septal cartilage was removed. What you don't see here is a very complicated procedure in which we took a cartilage from the ear to reconstruct the cartilage of the nose. We did a septal mucosal hinge flap underneath to increase the lining, and then did a paramedium forehead flap. Really the same procedure that Suture was describing in 800 BC. However, we used it from the forehead in this particular area as opposed to from the arm. And this is an example where we can get a very good result in the patient using plastic surgery. Obviously, a defect like this can be life-changing to an individual in terms of their self-esteem, and sort of socially, this could be very devastating. So here's another example where we really do have impact on people's lives. Cleft lip and palate repair. This is something that's usually in this country done on a humanitarian basis. Cleft lip and palate is not very common in the U.S. population. However, when it does occur, the incidence is much higher in Asians, Latinos, Native Alaskans, and Native Hawaiians. This particular area of plastic surgery is usually not really done in the United States too much. However, in those particular areas where there's higher concentration, mainly in the coastal areas and on the islands, in particular in Alaska, we will have a lot more of these particular patients that are involved in this. And this obviously is not only a feeding issue for children who are greater than between 3 months and 1 year old, because they can't form a seal around a nipple, but also of speech and chronic ear infection, which can lead to hearing loss. So when you repair a cleft lip, that is going to repair their form of how they look, their function of how they're able to suckle. But when we repair a cleft palate, you're actually repairing or improving their function to able to communicate with others, and also to prevent chronic ear infection with chronic hearing loss in these individuals. So these are pretty gratifying sort of surgeries to do in patients as well. Now we're going to talk about breast cancer reconstruction, which is a very large mainstay of plastic surgery. Breast cancer is very prevalent in the United States. It's about 13% of the population in the United States will develop invasive breast cancer over their lifetime. That's about 1 in 8 women. In men, breast cancer does occur as well. It's about 2,700 cases per year, and the incidence is about 1 in 833. However, they're treated exactly the same. So men do get breast cancer, however, not as much as women, but this is something that we would do in both patient populations. In 2021, it's estimated that we're going to have a little bit over 280,000 new cases of invasive breast cancer to be diagnosed in women in the United States. 50,000 cases of non-invasive breast cancer called in situ breast cancer, which is a pre-cancer, which can be treated just as a cancer, is also expected to be diagnosed this year. So we're looking at about 330,000 patients who will require breast reconstruction in the event that they receive a mastectomy, which can be quite common in certain situations. The incidence of breast cancer, or the cause of breast cancer, which is linked, some of them, a minority of them are linked to known gene mutations from BRCA1, BRCA2, also known as BRCA1 and BRCA2 gene mutation. Those are some of the causes. However, the majority of the causes, 85% of the breast cancers, have no family history of breast cancer, and they occur to a genetic mutation that have to result of aging and life process, sort of a gene mutation that has no genetic cause to it. When we're looking at breast reconstruction, this obviously is a very broad topic here in itself. But if you look at the chart, and you start at the top, if you look at implants, breast reconstruction can be done by using implants, or it can be done using their own tissues called autologous tissue, or actually can be used as a combination of both, if your own tissues and using an implant. And here we're looking at breast reconstruction, which is 137,000 procedures last year. Saline implants and silicone implants. Silicone implants, obviously at 96,000, is much higher than saline implants. And then we have something called a pedicle tram, a free tram, and a deep flap. And not to get into particulars in this case, but that is basically using the patient's own tissues to reconstruct the breast. So there's basically 2 ways to reconstruct the breast. One is using implants, and one is using your own tissues, autologous breast reconstruction. Generally speaking, when we have two options, that means that there's no one best option. So the majority of patients who are undergoing any surgical procedure, particularly plastic surgery procedure, they're tailored to the patient's needs. They're tailored to their limitations and what's possible within that particular patient, looking at them globally as a medical patient and saying, what can we do and what should we do in these particular patients? The timing of it can be done in an immediate basis at the time that the general surgeon removes the breast, or it can be done delayed at some point in time later. And this instance usually occurs in patients who need radiation therapy, who are just not ready to undergo reconstruction at that time. If you look at the schematic on the bottom here, when you look at where a lot of these breast reconstructions are done, overwhelmingly they're done in a hospital setting. Sometimes they can be done in ambulatory surgical setting, and very rarely done in the office. When you look at a plastic surgery patient, you're looking at removing the breast, reconstructing the breast in some form or fashion, maybe exchanging the implant out at another procedure, and then creating a nipple, and then maybe lifting a breast, or maybe doing a contralateral breast lift, reduction, or augmentation in order to match the other side. So when someone has breast cancer, you're looking at several different surgeries alone just from removing the breast to reconstructing the breast and trying to get the breast to look symmetric at the same time. So the overwhelming majority of the time they're done in a hospital setting, but sometimes in a freestanding facility and rarely in the office setting. Here's a patient, a typical patient. If you look to the picture on your left, obviously she had a left-sided mastectomy. As you really look closely at her left chest, you can see the scar, but you can also see this red area. That's an area of radiation therapy. Radiation therapy is needed in the treatment of cancer. However, it damages the local tissue. It kills the surrounding microscopic cancer cells that the surgeon cannot see or feel. However, it kills the DNA by attacking it kills the cells by attacking the DNA of the cells. However, the cancer cells are killed, but the non-cancer cells, the tissue around the area, their DNA is changed. And when you change the DNA of a cell, you're changing the characteristic of a cell. When you're changing the characteristics of a cell, that area will always be sort of at risk of having an infection, delayed wound healing, and capsular contracture. In this particular situation, this is a patient who would best serve by an autologous reconstruction, basically using the belly from the skin and fat from her lower belly and connecting it to the left side of the area where we take a little piece of the rib out. We take the vessel that's coming out of the heart, we reconnect it with a microscope, set that tissue there, reconstruct the nipple, tattoo the areola. And on the right side, as you can see, we sort of augmented and lifted the breast a little bit in order to match it a little bit better. And this is a sort of a typical presentation of a patient who had a mastectomy who's undergoing a reconstruction with autologous methods. Here's a patient that had a lumpectomy and radiation therapy. She didn't have a full mastectomy. However, they were able to do a lumpectomy, as you can see on the right side of the breast there. And she had radiation therapy. And due to the scarring from the lumpectomy and the radiation therapy, she had a severe distortion of the right breast area. In this particular situation, not only was it distorted, it was tight, it was painful, and it limited some of her motion. So we're able to remove all of the scar tissue, the rest of the breast, and then we reconstructed this using a latissimus flap, muscle from the skin and muscle from her back, turned it around, brought it laterally, and then put an implant in there. And on the left side, we augmented and lifted the breast in order to make them seem more symmetric while she's wearing clothes. Reconstructive surgery is very challenging, and that's what I like about it, because you can never, ever try to bring back what nature has already made. And it's very difficult and it's very challenging, and you'll always be sort of trying to improve. And in fact, our logo for the American Society of Plastic Surgery is sort of a broken circle. And that's to remind the plastic surgeon that you will never reach perfection. You can always strive for it. You can always aim for it. You can always try to prepare for it, but you will never achieve it. So therefore, you have to continue to do self-introspection and sort of trying to learn new techniques and ideas to try to improve to reach your goal. Here's an area of chronic wounds where this is obviously a non-ambulatory patient who has a sacral wound. these can be devastating to patients. Not only devastating to patients, but devastating to the caretakers. These are usually people who non-ambulatory for chronic reasons, from a very young age into adulthood. You'll have elderly parents taking care of these people, which is a very arduous task for movement, cleaning, medical appointments, and so forth. And this can be very, very tough on patients. And it's not in a very clean area. And this is what you see on the left-hand side. And the middle photo is what you see in surgery. We're able to take sort of a gluteal flap and advance it more medially to cover that area. If you look within this flap here, you see a little purple dot. And what that's doing, we take an ultrasound probe and we listen to where the blood vessels are. And when we remove a piece of tissue and relocate it, we make sure we encompass that blood supply. And that is, remember what I said earlier, is that we have surgical principles that we have to make sure there's no infection, clean, healthy edges, tension-free closure, and making sure we have adequate blood supply. So that dot right there is marking the central area of the blood supply that we're making sure when we move that island of tissue over, that it has blood supply with it. And the picture on the right here is just several months later to show the durability of it. This patient had been living with the wound for years. And we're able to close it during one surgery. And this has lasted for a very long time. And if cared for properly, this will remain intact. So we have to not only do a surgical procedure, we have to educate the family and the patients as well, so that they don't get a recurrence of these type of wounds as well. Here's another procedure where we have a sort of a trochanteric sort of wound. And if you look at the middle photo here, you can see a piece of hardware where she had a prosthetic hip. You have an open chronic wound with a prosthetic material, exposed, that is never going to heal. What we're able to do is open up the back thigh, remove a lot of the muscles anteriorly to cover that area, to fill that defect and close that skin. And this patient also had this wound for several years. She was treated at several different hospitals, actually. And if you look at the right leg, that had a lot of issues as well and had to be amputated. And this wound here was on the way to be amputated as well. We were conferring with our orthopedic colleagues who had requested some assistance in controlling this wound. And in efforts not to have that leg amputated, we were able to successfully cover that wound and effectuate healing of that area to avoid an amputation. If anyone knows can understand what it takes to take care of someone who's chronically ill, when they're missing a limb, it actually is much more energy expenditure of the patient, but also of the caretakers as well. Losing a second leg here would have been so much more difficult in taking care of this patient. And I'm glad we were able to save, her limb. Here's an area of thermal burns. In Fairbanks, obviously frostbite will be an issue. Dr. Wen, who's been a part of the community there for years, has a vast experience, much more experience than I do in frostbite care or chronic, traumatic wounds from bear injuries and things like that. However, this is something in that realm where we have a wound. It's a thermal burn, and this is a full thickness burn where all the skin of the entire palm is removed. The issue is with the palm is that the palm has something called glabrous skin. It's usually a lot thicker and a lot tougher because we're usually handling things. So this is a very difficult area to try to reconstruct. So we're able to take some skin from his abdominal area, a full thickness skin graft, not just a split thickness, but a full thickness skin graft, which is much more durable, and cover that particular area. And over several weeks over time through the healing process, this is all hyperpigmentation. However, he does have skin covering that hand so that he can actually use it. And that's just an example of something which is basic as a full thickness skin graft that we can use. On the cosmetic side, here is rhinoplasty surgery. Rhinoplasty surgery can be used for form and for function. It can be used for breathing issues where people may have had a traumatic injury or deviated septum where they can't breathe and it's causing them difficulty, or they just don't like the appearance of their nose. A lot of times it can be done in combination. These are just typical examples of doing a septal rhinoplasty where we're correcting maybe the deviation of the septum, doing something called a spreadograph, opening up the airway, and at the same time doing some cosmetic work to improve the appearance of the nose as well. Off to breast augmentation. Breast augmentation, as we know, is probably one of the most popular sort of requested plastic surgery sort of procedures. And breast augmentation has gone over a lot of change over the years. If everyone remembers in 1991, where the FDA put a moratorium on silicone implants because there were some reports of diabetes, collagen vascular disorders, and lupus being caused by silicone implants. And back then, we didn't actually have randomized trials showing the efficacy and safety of breast implants. So since that evidence was not there, the FDA put a moratorium on breast implants. So between 1991 and 2007, silicone implants were not used. It was just saline implants. And during that time, certain centers within the United States were tasked to perform these randomized controlled prospective studies to look at the efficacy and safety of breast implants. And in 2007, it showed that there is no associated risk of lupus, diabetes, or other collagen vascular disorders. So silicone implants came back into the market in 2007 for reconstruction and in 2008 for cosmetic purposes. When we look at breast implants, however, there's certain things we have to look at. We look at the size, obviously the volume, how much the patient would like, how much they require, or what's even natural. Some patients will want things that are just not natural, and it's our sort of job to educate the patient on what the short and long-term goals of a breast augmentation will be. We're looking at the material, whether it's a saline implant or a silicone implant. Some people have, for some reason, they say, oh, I don't really like silicone. However, every implant that is available, whether it's saline or silicone, has a silicone elastomer shell, a rubber shell. So that's what we're getting in terms of the silicone implants. Also, years ago, when implants were first made in 1960s, they were very, very sort of soft and gel-like. And then over the years, we cross-linked the silicone more and more. As we cross-linked the silicone, the more firm it became. So if you look at a piece of plastic anywhere in our house or in the hospital, that could be silicone. And it depends on how much we cross-link it and how firm or solid it's going to be. So we have something now called form-stable gel implants, which is known as the gummy bear implants. And that usually is sort of the more shaped, form-stable, less liquid type of implants on the market today. You can look at where the placement may be, above the muscle, below the muscle. And there may be different reasons why we do that, or one versus the other. And also the different type of incisions. Incisions can be around the areola, it could be underneath the breast, it could be in the armpits, it can even be around the belly button. So those are the considerations that we're looking at for breast augmentation. But the general goal is to make a woman appear to be more symmetric and give more confidence and symmetry to the appearance. And here's an example of a slight breast augmentation that is not over proportion to the patient and actually fills her out quite nicely. If you can see the picture on the left, you can see a large cleavage area. In the procedure on the right, we bring in that cleavage line much, much better aesthetically pleasing. And here's a side view of that as well. Here's a patient where we're looking at a breast lift. This is a patient who she was very young. She's probably in her 20, maybe 23 or 24, who had large breasts and the position of the breast. So large breasts can be very difficult and heavy for patients, uncomfortable, but also the position of the breast also are very important. And if you think about having a large backpack, if you have the backpack hanging very low as opposed to having it cinched up onto your shoulder, it could be the same weight, but where you carry that weight actually can have an impact. And this particular surgery here is a patient who underwent more of a breast lift, a somewhat slight of a breast reduction in terms of what the goals were. And you can see it's aesthetically pleasing. She was happy because we were able to lift the weight off of the breast as well. And this is a side view. Lower eyelid blepharoplasty. You can see the top picture is very subtle. You can see some bags under the patient's eyes here. And as a result of maybe an hour and a half surgery, we can see below, underneath the eyes, it's much more awake looking. I think the goal of plastic surgery is that people will notice, but no one will know. You don't want an exaggerated response or to change someone's ethnicity or dramatically change their look. You want to be able to freshen up your look, make sure that, hey, you look a little bit younger, but not drastic. You don't want to change anything. And this is a classic example of sort of the subtleties of what we can do in plastic surgery. So as we're wrapping up here, I really want to give sort of an overview. As you can see, we went from major reconstruction to cosmetic procedures. There's many things to talk about in plastic surgery, but I wanted to really give sort of a very short sort of snippet, sort of presentation of what we're going to be able to bring to the Fairbanks area in terms of medical procedures and cosmetic procedures, those both invasive and non-invasive, and basically be able to entertain any questions that anyone may have at this particular point in time.
Thank you very much. Questions? Yes, sir. 1 second.
I have several questions, but I'll take my turn if there's others. When does plastic surgery, reconstruction surgery, and cosmetic surgery, for example, cosmetic surgery is almost never covered by any insurance, but reconstructive surgery may well be. For example, I suffered a bilateral subdural hematoma of the head, brain bleed. I ended up with 4 holes in my head, for which later I needed to have filled because they were soft spots. And I was offered 3 different materials, pig bone, cadaver, and plastic. Now, this was 15 years ago. I selected the plastic. And for the first 5 years, it was perfect. And then they started to concave. They sunk in. As I talk to you, I have concave. They're fine around the edges of the hole, but the center goes down. What was defective about this procedure? The plastic or the cosmetic person did offer to redo it, but I was concerned that I'd end up with the same problem.
Sure. I would have to say I can't comment on what may have been done wrong, if anything, actually. Number one, from what you're describing to me, that's not a cosmetic issue. It's a reconstructive issue. So reconstruction is to build back a body part that was either destroyed or malformed from some issue, whether it's a disease or an accident. If you fell down, had a subdural, had to have craniotomies due to that medical issue, reconstructing an area should not be cosmetic. I don't know the particulars of the insurance situation in this particular case, but that shouldn't be. There are different trains of thought in terms of what we can do. Like I said earlier, when a surgeon or a doctor gives you several options, usually there's no one best, or that we would say, hey, this is the best option for you. So cadaver bone is an option. Polymethacrylate, which you probably received, as an option. Pig allograft is an option. It all really depends on the overlying tissue that you have, the blood supply, the amount of the defect. Sure, if you have a foreign material within your body almost will never incorporate it long term. That's just a general principle. Therefore, that's why some individuals may elect to do something a little bit different in terms of your own tissues. For instance, not saying in this particular situation, but what can be done in other situations is that you have a cranial defect, we can take portions of the rib. The rib is sort of a long curvature. We know as a rib, we can split that rib. You split many ribs. Now you have a curvature that you can, if my fingers are ribs, you can have a curvature and you put that onto the cranium. Well, the bone or the dura underneath will actually heal to your own bone. That may have been an option. However, we look at the surgery procedure in terms of how risky it is, and then we look at the patient as well. Sometimes the surgery is risky, but the patient is very healthy and low risk, we'll do the surgery. Sometimes if the patient is high risk because of medical issues, conditions, or trauma, and the surgery is very high risk, that person may elect not to do that particular procedure. That may have been in your situation. But generally speaking, yes, if you did get another procedure with a foreign material, plastic material, or methyl methacrylate, most likely, it can happen again over the long term. And those are the risks of using non-biomaterial. There are risks of using biomaterial, where you can remove the portion of those ribs, put it there, and it not take. Now you don't have portions of those ribs. You sacrifice that. That's the risk in and of itself. So that can be some of the reasons there. But generally speaking, I think that if you knew exactly what material you had a very long and in-depth and healthy discussion with your surgeon in terms of the risk and benefits. I'm sure he or she would be able to give you sort of adequate sort of recommendations, or at least steer you to a center in the United States that can give you sort of the treatment that you may need, or maybe even a second opinion may be helpful in your situation.
Of the options of material, if you had a need, what would you have selected?
Generally speaking, it's very difficult to opine on a case that I wasn't able to examine. But in general, I prefer autologous tissues. One's own tissues will heal to itself much better than a foreign material. That's just in principle. Have I used other materials? Yes. But my first option will always be your own tissues.
Well, I had back surgery, serious, and they did take bone from the end of a rib. And of course, it worked perfectly. So sticking with your own body parts probably is a better idea.
Yeah.
Yes, your introduction said something about, and this can be done in Fairbanks. Can any of this be done in Fairbanks today?
Everything I presented can be performed in Fairbanks.
It can.
Yeah.
Really?
Every procedure that I just presented, all these cases are my cases that I've done. And this can be done within Fairbanks. I've visited there several times. I've talked with the staff. We looked at the operating room. We looked at the equipment. I have a surgical first assist. I've experienced in this area. They have the most updated equipment. And that's what we intend to do. And that's the purpose of this presentation as well, to bring these things, which I just talked about, to Fairbanks.
And where can I call or go to find out?
Yeah, there's Amy Sharp and Veronica Parr who's there. They'll be able to help you with that after the lecture's done. And we'll be seeing consuls probably sometime next month. I think I'll be there.
I just want to also say your presentation is first class. Thank you.
Oh, thank you. Appreciate it.
Other questions?
My question has to do with, I know lots of people are interested in procedures. Do they have to have a basic level of health before you would consider doing an elective procedure? You have to counsel people.
Absolutely. A lot of times people look at plastic surgery and think of it as something that is not risky. Plastic surgery can be very risky in patients in terms of, let's say, liposuction. Liposuction, we put a rod into your skin and we are removing tissue, but you have blood vessels there. So you can lose a lot of blood through that particular surgery. Looking at the thigh surgery that I did, you can lose a lot of blood there. The breast surgery, you can lose a lot of blood. Generally speaking, we look at a patient medically like any other surgery procedure would. We look at the patient and we look at the surgery. The majority of the time, the surgical procedures themselves in plastic surgery are not as high risk as, let's say, heart surgery or some orthopedic surgery or general surgery. So our procedures are not as risky. However, we're very careful in terms of the patients. For instance, I'll never do any elective surgery on someone who's an active smoker because smoking decreases the diameter of the blood vessels, and that goes against one of the surgical principles in making sure we have adequate blood supply. So if there's a wound that's present, I have to cut out that wound, therefore making that wound even bigger. Then I have to remove tissue from another area and remove that tissue over to the area to close, thus creating another wound. So if I create a larger wound that I cut out and then I remove tissue to move it over and that doesn't survive, we have a much larger wound. So we're very careful in terms of our planning and in terms of our analysis. I would say the overwhelming majority of the patients who come for plastic surgery are candidates, over 95% of them. But there are certain situations where maybe too much high blood pressure, heart problems, unresolved, cardiopulmonary issues, smoking and things like that. Sometimes they may be prohibitive, but usually with some tinkering and some care in terms of smoking cessation, blood pressure control, looking at going to your cardiologist and making sure your heart is optimized, they can then become surgical candidates at that time.
Other questions?
I just had a little further question about the flap style or the transplant style breast reconstruction.
Yeah. Mm-hmm.
And I know there's various versions and, it all depends on the patient, but
sure.
Well, two questions. One to follow up. So now, if I understand it correctly, at this time in Alaska, there's not an option for that type of surgery, either in Fairbanks or Anchorage. I guess, is that a question? Do you know the answer to that?
In terms of the autologous tissue?
Yes.
Yeah. I don't know what is available in Anchorage. I'm not sure. But we will be able to do autologous tissue. There's different types of autologous tissue reconstructions. There is a pedicle tram flap, which is available. There's a pedicle latissimus flap, which is available. One of the examples I did there. There's one called a deep flap, a deep inferior epigastric artery flap, which involves a little bit more of instrumentation and requirements and ICU monitoring and care that we may be able to do over a period of time once we get settled up in Alaska. But we will have the majority of autologous reconstruction as soon as I land there.
Okay. And I guess my follow-up to that, in those situations, from research, I've researched the same thing where it takes a bit of hospital stay after the transplant to make sure that the tissue takes. Is there, what kind of things would you look for? Or what would make that fail, I guess, in the long run?
Sure. So the deep flap, I think you were referring to as a transplant, is a very fine surgery. So the vessels are usually, 1 to 2 millimeters in diameter. And the sutures that we use are usually the diameter of a person's hair that we use under a microscope. So the connection is very, very small. When a connection is very small, a kink in that vessel, in that connection, can stop blood supply. Spasming of the vessel that's already sort of microscopic can inhibit the blood supply. A very small blood clot within that connection, because the turbulent flow can also cause inhibition of the blood supply. Smoking in patients in terms of vessel spasming down. You have a vessel that's already 2 millimeters and it's spasming down to less than 1 millimeter when you're looking at maybe 800 grams of tissue to perfuse. That can cause ischemia as well. So we're generally looking at patients' overall health. Usually the ideal candidate in a patient like this would be in their mid-50s to late 50s, a non-smoker, no significant heart, medical, or lung problems. And that's usually what we would need to be a candidate for that surgery.
I'd like a further clarification on the difference between cosmetic and reconstructive in terms of insurance coverage. Is the term medically necessary what separates insurable surgery versus you're on your own?
Yes. Now, they will all depend on the insurance company. Okay. So generally speaking, medically indicated surgery is a surgery that is indicated because of a medical issue. Cosmetic surgery is indicated because the patient wants it. That's really the defining point. So if a patient wants a different shape of their nose, then that's a cosmetic procedure. However, if a patient underwent a trauma where the nose is deviated to the point where they can't breathe, then that is an insurance case. Sometimes if a patient may want a breast lift, and the breast lift is a cosmetic procedure because they want it. However, in some situations, if the patient gets repeat chronic fungal infections underneath the breast, that's refractory to medical management over several years or several months in period of time, that's documented, that may be something that could be presented to the insurance company and say, okay, this patient wants a breast lift. However, it is medically indicated because of chronic fungal infections, skin infections, which may be approved. So there is no guiding authority on what is approved or not approved, the guiding authorities are independent insurance companies themselves.
I have a number of questions online here.
Okay.
Have you ever performed microvascular surgery for a breast reconstruction in which a blood supply is moved from a donor site to the reconstruction site? And could you give examples if so?
Yeah, so the patient in the photo, in the slides, she was a microvascular case. She was a deep inferior epigastric artery flap where we took the skin and fat from the lower abdominal area to the bikini line from the rectus muscle, remove that, put it onto the back table, open up her scar, remove the piece of her rib, and take out the artery that's coming from the heart, and then connecting that and placing it there. So one of the examples there was an example of that particular question.
In talking with colleagues in Fairbanks, and you had mentioned Dr. Wennon, what do you predict as the greatest needs in this remote rural environment?
Yeah, that's a very good question because I visited several times, and I was there about a month ago. And from what I can see, there's a very broad spectrum. I think there's several pockets of need. I think there's a very large pocket of breast reconstruction that is needed. Breast cancer diagnosis is very common. From what I understand, is about 80 per year done in the Fairbanks area. About 25 to 30% of those require breast reconstruction who are not getting them at that particular location. So being able to do the breast reconstruction on site in Fairbanks, able to make sure that we're able to do this in an immediate basis, which is beneficial to the patient in terms of the outcome and their recovery. But it obviates them from actually traveling to a different state or even Anchorage to go ahead and for follow-up care or any potential complications that may occur, as happens from time to time. It's much more convenient to happen here. I think that's one. I think traumatic injuries, obviously. The time that I was there, we had a severe burn patient that was healing quite fine. However, in some situations, electrical burns, they don't do very well. So austere environments where you're having either a frostbite burn, you're having an electrical burns, you're having some type of animal attack, those type of traumatic wounds obviously would be areas that we would need to focus on. That's a need there. And I also think there's a very large cosmetic need there as well, from what I can understand. So I kind of see most areas that I just looked at, with the exception of cleft lip and palate, that are applicable to the Fairbanks area in terms of medically indicated, elective medically indicated breast reductions, the wounds with the Denali Center, injuries, cosmetic surgeries, and breast cancer surgeries. So I can't answer that question until I'm there. But from what I can see of my 3 or 4 visits that I've been there so far, I see all those areas which I presented. And that was kind of the reason why I made the slides for that, because that's kind of what I see.
And we'll be respectful for your time because I know it's about to turn midnight at your time. But a couple other quick online questions. What is the local support efforts needed to support plastic surgeries in Fairbanks, including staff, other physicians, social services?
Sure. Yeah, that's a very good question. So I've been working with Foundation Health for about a year, a little over a year and a half. And I would have to tell you that they have been able to comprise a very comprehensive team. So not only myself, but I had a person who I've worked with for several years who has assisted me in the operating room. She actually relocated to the areas already there. They were able to go ahead and do that. We have a dedicated plastic surgery nurse. We have an entire team of 8 individuals in our plastic surgery clinic. We're being integrated within the operating room. We toured the operating room. We have all new surgical sets that have been ordered and are being teed up. All implants are being sort of allocated to our particular area. We've been given a certain amount of operating room time to make sure that we're able to take care of the need that's there. Obviously, there's been some lacking in that situation. We've been involved in the multidisciplinary breast care conferences. We're looking at a lot of different, areas in terms of liaison with the military facility at Bassett. I visited there and made connections with some of the surgeons there to make sure that we have some type of dialogue and at least be able to take care of those particular patients there as well. And we're really sort of in the strides of everything. We're just re-renovated a clinic that will be over in the Doolittle building for at least a year and a half. We've actually been in contact with architects in weekly meetings and re-renovating the third floor of the hospital, potentially for integrated plastic surgery, wound care service, and potentially dermatology combined service over the next year and a half. So there's been a lot of sort of pre-planning and forethought about this on terms of the foundation side, as well as my side as well. I didn't want to go into a particular community and not have something to be set up for success. I wanted to be able to make sure that we had not only the time commitment, the financial commitment, and the equipment sort of attention that we have, the demands of plastic surgery, and also knowing that working for the hospital, there hasn't been that sort of relationship just yet. So we've been learning off of each other. And I think I'm able to bring a certain amount of at least education and, specialty specific knowledge and capabilities to the area. And I think that the leadership for the hospital has been very open-minded. And I think they see the need for plastic surgery and what we can do. For instance, plastic surgery, we operate on our own, but we also operate with other services as well. There may be another service that may have a complicated case or have a difficult wound case that they may not be comfortable doing on their own. However, if they have a team member as a plastic surgeon, they may be able to embark on that. So not only will we be able to affect some of the things in our lane, but we're also able to help and assist other specialties do things as well. So I do think that I think we have a very good collaborative team, and I'm very excited to see what's going to happen within the next year or so.
I have two other fairly quick questions online.
Sure.
One more chance around the room, and then we'll close it if you don't mind. Could you estimate the number of tram flap surgeries you've performed during your career? Thank you.
Sure. Tram flap surgeries. When I was in Hawaii, I was the only one with actually in the state of Hawaii doing tram flap surgeries. And in the state of Hawaii, we had probably a little bit, I was relegated to the military population. So I had about maybe one a month. So I had about 12 a year for about, 7 years there. When I moved to Fort Belvoir, we had Walter Reed up the block. So I didn't have the support in terms of the ICU care. And with deployments, I didn't do as many in the Fort Belvoir Hospital. But I would say total, I probably have about 45 to 50 under my belt in terms of microvascular reconstruction. The pedicle tram flaps or the pedicle latissimus flap, the non-microvascular surgery, those type of autologous surgeries, I would do probably about one every 2 months over the past 5 years. So you can calculate that up. That's kind of about a round number for it.
And here's a question for the night. When are you open for business?
Yeah, we're getting to that at this particular point. Like I said, we are re-renovating certain particular areas. I'm currently still active duty, and there are only 13 plastic surgeons in the Army, 3 who are getting out this summer. There's a very severe shortage. One in the DC metropolitan area. We have 2 new graduates coming out who are coming in this month. So I think I will be there probably we had planned about 2 or 3 weeks from now, but it may actually be a little bit longer, but it will definitely be within the month of September at the latest.
In your presentation, all of your graphs, were all children or women. And I understand there's a very huge growing men for plastic surgery or at least cosmetic. What are the procedures that men are pursuing?
Sure.
Most likely.
Yeah. So procedures for males. So I would say the procedure for males are usually in the 20s to 30 and maybe even 40-year-old range. And those are usually gynecomastia surgery and liposuction surgery, abdominal etching in particular. So abdominal etching, so liposuction can be done to remove fat, but liposuction can also be used for sculpturing and redefining. So in male surgery, that's usually sort of the more trends. Rhinoplasty surgery in terms of reshaping the nose has always been a mainstay of male plastic surgery, but what's upcoming is liposuction. Liposuction in men is something that's occurring now that usually hadn't occurred, years ago.
It is now August 11th in Virginia, and I would like to thank you very much and ask the folks just to give Dr. Martell a hand for an incredible talk.
All righty. Thank you very much. I appreciate it.
We look forward to seeing you soon. Thanks for coming.
Likewise. All right. Thank you.
Good night.
All right, good night.